That's a very important topic. That's something I consider definitely one of the most unmet needs that exists for all MPN patients, not only myelofibrosis patients, but also patients with ET and PV, where there is a numerous studies over the years, mostly credited to Ruben's method group, that took first benchmark study with the international survey and then the landmark MPN quality of life. That actually showed us how bad we were in assessing the symptoms, how bad the currently basically established scores with the cancer societies were for MPN patients, and then developed the new tools such as the current MPN-10 or MPN-TSS that's used broadly in all MPN patients, nicely validated, put in over 30 languages, and should be used around the clock every 3 to 6 months. That's at least recommended in current guidelines and also a good clinical practice, which could indicate the disease progression. And then I think the biggest move there and unmet need would be patients. They are on standard of care therapies and are heavily symptomatic. We know that the symptoms are not proportionally evolving over the patient's disease course. Some improve, some worsen. For example, fatigue is a very significant symptom, which we don't even know the attribution to. Could be disease, could be drugs, could be just daily life. But certainly we have a lot of work to do. And then we have some drugs that improve the symptoms, and we have drugs that are great for spleen, for disease modification, as we call, but they lag behind the symptoms. For example, which we like to use interferons for patients with ETs and PVs, but they're not the best drugs for symptomatic patients. Indeed, there has been, for example, post-hoc analysis of the MPN-RC studies in patients with ET-PV showed that actually patients with lower burden had maybe worsened symptoms at the beginning. So that is something to really consider.